Hello, I'm Angeliki Vaganzis. I'm a neurologist and headache specialist. I practice at the Graham Headache Center, which is part of Harvard Medical School in Boston, Massachusetts. I'd like to talk to you about the relationship between sleep and migraine. We know that people with migraine, up to a third, report sleep disturbances in retrospective reports. Specifically, they report difficulty with getting to sleep and staying asleep, poor sleep quality, a lack of refreshment after sleep, higher rates of snoring. We know that these relationships are not solely explained by comorbid anxiety or depression, but we aren't entirely sure what they mean. Furthermore, we know that sleep problems are more common in those with chronic migraine than with episodic migraine. In one study done out of the Danish Headache Center using an epidemiologic sample, 40% of patients with chronic headaches reported a sleep problem, and 27% of those with episodic headaches reported that. It's natural to look at the timing of sleep with respect to a migraine attack. Now, if we look at the timeline of a migraine attack, there are various instances where sleep is mentioned. In the prodrome, patients may report feeling tired, yawning, or having difficulty getting to sleep, in addition to other things like hunger, thirst, and irritability. During a headache phase, patients might report, again, difficulties getting to sleep or feeling tired. Interestingly, some patients use sleep as a medication, if you will, trying to get to sleep so they can abort their headache attack. After the headache phase is over, many patients will feel a sense of postdromal fatigue, which can last for several days following a migraine headache attack. When we look at sleep disturbance as a trigger, this is actually reported by about half of those with episodic migraine. It's both in retrospective reports of sleep, as well as some prospective reports of those with small samples of those with chronic migraine. A study that was done here in Boston that I was involved with showed that although patients with migraine did report that sleep disturbances were a trigger, when they were followed prospectively, and this was 100 patients with episodic migraine, there were in fact no changes to their sleep duration and other sleep measures, including sleep efficiency, which is the amount of time someone's asleep over the amount of time they're in bed, and their amount of time that they're awake after they go to sleep, which is also known as WASO. So when you measure this objectively in the naturalistic setting using something called an ActiWatch, which measures movements, it does not appear that sleep changes in the night before a migraine attack. When you look 2 nights before a migraine attack, there's a suggestion that there might be a decrease in sleep efficiency. It's unclear what this means, and these studies need to be replicated. When you look at sleep characteristics the night after someone's had a migraine, we see that there are not dramatic changes to their sleep, either objective changes as measured by actigraphy or in their perception of their sleep quality. This is based both on a study that we did here using adults with episodic migraine, as well as a study that was done using children. Now, headache can also arise out of sleep. This is called sleep-related migraine. About 2/3 of those with migraine report occasional headaches awakening them from sleep. This can increase with age, and limited studies that were done in the 70s and 80s using polysomnography reported that these patients may be more likely to wake up out of REM or slow wave sleep. However, it's unclear if this is an actual association with sleep or a probability. It's unlike cluster headache, which shows a clear diurnal preference and association with sleep. Now, when we look at these potential shared biological pathways between sleep and migraine, there are a few areas of common anatomy as well as physiology which might help provide insight. One of these areas is the hypothalamus. The hypothalamus is a very important yet small structure which includes a flip-flop switch, which is very important for sleep. This flip-flop switch is responsible for transitioning from sleep and wakefulness, and its malfunction is implicated in disorders such as insomnia. In migraine, we know that there's hypothalamic activity, which is altered in the 24 hours prior to pain onset. Now, there's another system in the brain that's more newly discovered, the glymphatic system, which is responsible for clearing the brain of interstitial waste. That's only active in sleep, or primarily active in sleep, as far as we know. It's unclear what the role of this system might be in migraine. However, animal studies done here in Boston show that cortical spreading depression can result in temporary impairment of glymphatic flow in a mouse model. Lastly, there are common signaling molecules that are important in sleep disorders as well as in migraine pathophysiology. One of these is serotonin, which in sleep promotes wakefulness and inhibits REM sleep. In migraine, patients are at a low serotonergic state interictally, and there's early mobilization of serotonin stores during a migraine attack. Dopamine promotes arousal via hypothalamic input into the periaqueductal gray in sleep. And in migraine, it can modulate neuronal firing in the trigeminal-cervical complex and is implicated as having involvement in the premonitory phase with yawning, drowsiness, mood changes, and irritability. Nevertheless, there are many questions that remain unanswered into sleep and migraine common pathophysiology. In the meantime, what does this all mean clinically? Well, we know that comorbid sleep disorders are not uncommon, and that when we identify patients with high risk for insomnia or other sleep disorders, those should be treated independently of their migraine attacks. In particular, treatments like cognitive behavioral treatment for insomnia can be particularly effective, and in small pilot studies have shown to also improve the frequency of migraine headaches. Patients with migraine should also be encouraged to maintain normal sleep times and healthy sleep habits, in addition to identifying those patients with particular sleep problems. We don't know whether there's support to use sedating medications to avoid headache attacks, although we know it's frequently done. Further research really needs to help elucidate our current clinical practices, as well as to understand the basic science mechanisms underlying this very interesting relationship between sleep and migraine. Thank you.